Thank you. So the case is, each case is having a 5 vignettes. So we will discuss around 30 questions, and I have the answers with me also, but I will try to engage you all so that I just want to know that how is your preparation. Okay. So this is a 28-year-old female admitted to labor G2 P1 and admitted to labor with delivery at 28 weeks of gestation, complaining of a severe headache with blurred vision, blood pressure 200 by 110, and with 2 plus proteinuria on urine analysis. The repeat blood pressure after few hours later is 160 by 110. Lab studies shows a normal hematocrit, normal platelet, and liver transaminase levels were also normal. The blood pressure was 180 by 110, the heart rate 123, the respiratory rate is 25 breaths per minute, temperature is 34.2 degrees Celsius, oxygen saturation is 98% on room air, and on physical examination, the patient was not having any pallor, not having any icterus, no swelling of only the swelling of hands and face are there. CNS finding the patient is complaining of blood vision, and then the patient is having a severe headache. The protein, the urine analysis, 24 hours urine analysis is showing a more than 300 milligram protein per 24 hours. Okay. Now, yes. Now this is the question. So who is going to define preeclampsia and severe preeclampsia? Just one or two words. You can unmute yourself and then you can define.
Sir,
Yes, Pankaj.
myself Pankaj, sir. Yeah.
Yes, yes.
Sir, preeclampsia is defined as a BP of more than 140 upon 90
Very good.
uh, after 20 weeks of gestation without any history of hypertension
Hmm.
with proteinuria
Hmm.
of more than 300 milligram in 24 hours or 1 plus.
Okay, very good. So now Pankaj has very well classified preeclampsia. Who is going to classify severe eclampsia? Anyone? So anyone? Gandhi, Annika, Mohammed, Salah, anyone who wants to answer?
Okay, let me attempt. Severe preeclampsia, it's defined as elevated blood pressure of more than 160 over 110 millimeters mercury, in addition to the other symptoms given for eclampsia, which includes proteinuria.
Okay. Okay. Anyone wants to add something else here? Because when you will appear in real-time EDIC examiner, the examiner will ask the question like this only. And then they will not ask you that you are telling right or wrong. They will just give a marks. Okay. But the thing is that you can face the examiner and then you can answer. We will discuss all those questions here, question and answers also. We'll try to finish within time. Let's see how much we will going in depth also. So any other who wants to attempt this question, that what would be the other cardinal symptoms? Because the other symptoms should be there to establish a patient with a severe preeclampsia.
Proteinuria.
Yeah. Okay.
Involvement of other organ system.
Okay. Good. At least I want that you all guys should have means you can add something to it. Okay. So we'll discuss later on. Now come to the next part, that can you tell us 5, 6 appropriate laboratory investigation? The second question, necessary to assess the severity of the preeclampsia. For assessing the severity, what investigation that you want in this patient, in this 28 years old female? One by one, anyone can answer what laboratory investigation is really required for assessment of severity of preeclampsia.
The complete blood count, including platelet count.
Yes, good. So
LFT
this is 2.
creatinine.
Okay, serum creatinine.
Lactate renal function, lactate renal function.
Renal
Okay.
functions.
Okay, very good. So many of you are right. Few of
Magnesium.
you still missing.
LDH level.
Okay.
24 hours protein,
Yeah.
urine protein.
Okay.
LFG,
Now the important thing is that how should we are going to manage these patients? Definitely delivery is required. No expected management. You can't wait for these patients. Delivery is utmost desirable thing for this patient to be taken care of. But fourth important question is again a very interesting question, simple question, that what could be the potential causes of convulsion, especially in third trimester of pregnancy in this patient. In this patient, we will talk about this patient. What could be some cause of convulsions? Can anyone enumerate the potential cause of convulsions? Eclampsia can have, but yeah,
Venous
eclampsia.
sinus thrombosis.
Very good, very good. Who said sinus thrombosis?
Dr. Namrata.
Okay, Dr. Namrata, very right. So it could be your cavernous sinus thrombosis or sinus thrombosis, right? Any other cause?
Hemorrhage, intraventricular hemorrhage.
Praise
Yes,
syndrome.
yes,
Praise
yes,
syndrome.
very good. Intracarinal hemorrhage as well, very good. And so this is how you have to approach. Okay, okay. So now the fifth number question, I have already taken a class that what agents that has to be avoided in the management of severe hypertension in preeclamptic patients. Anyone have any idea that which is not to be used?
ERBS,
Okay,
AC inhibitors.
okay. Why you doesn't want to use ACE inhibitors? What it will do?
It may cause
Teratogenic.
profound the hypotension,
Yes, very
as well as
good. Yes. It will cause. So now I think many of you have done almost you have answered few of the questions. So just let's see the answer. So first, preeclampsia is defined as the blood pressure at, it was very rightly said that the systolic blood pressure has to be 140 and diastolic has to be 190. We will have a very quick look so that we can go to the maximum case vignettes. Proteinuria is to be more than 300 milligram protein in 24 hours collection. So I don't think so that now anyone has any confusion in defining that at least two cardinal features has to be there for defining preeclampsia, right? For the second part, for severe preeclampsia, I think I think you are right in defining the severe preeclampsia also, that blood pressure 160 and diastolic blood pressure 110, but at least two occasion and 2 hours apart has to be taken, has to be told for complete definition. So 2 hours apart and at least two occasions, the blood pressure has to be more than 160 with diastole more than 110. And these patients have to be, that many of you have told, right, that serum creatinine has to be elevated. The patient will have a proteinuria, but here from 3 it is ranging to 5. So 5 gram of proteinuria, so 5000 milligram in 24 hours collection is to be there. The patient will have a edema, the patient will have a visual disturbances, patient may be having a seizures, the patient will have epigastric pain, thrombocytopenia, oligohydramnios, IUGR features, placental abruption as well. So these are few of the associated findings which you all guys have to enumerate, because in each enumeration you will get a different marks. If they will ask the questions like tell us the definition of severe eclampsia, severe preeclampsia. So if you are telling 160 by 110, you will get half marks. But if you are telling two occasions, 2 hours apart with features of proteinuria, oliguria, serum creatinine elevated, then you'll get full marks. Okay. Now come to the next part. So the laboratory investigation, many of you told, right, CBC. Why CBC? If you'll tell like that, CBC, because we want to include a platelet count, we want to see the thrombocytopenia, we want to see AKI changes in this. That's why we need a renal function test. We want to see transaminitis or elevated serum bilirubin. So we want to do a LFT. We want to see any deranged in the coagulation profile, like deranged in the INR or coagulation defect. We want to do so many of the times what in the previous examination also what I thought that these two questions, these two answers will not be told by any of the students. Many of you have already tried to miss these options like blood grouping and typing. This is very important. Blood grouping typing, as per literature, it says that antibody screening and blood typing is again important if you are trying to manage. So this is again one of the important laboratory investigation. And then 24 hours urine collection apart, in spite that you have done a 24 hours urine collection, but you have to include it in your laboratory diagnosis as well. So this is again important. So I'm sure that many of you must be answering these four, but these two are important. But among these two, this is very, very important. Okay. Now coming to the next part. So what are the potential causes? Again, you all have make it damn right. So it is one of the common cause, hypoglycemia. I'm sure that every one of you is knowing this. Intracerebral hematoma or intracerebral hemorrhage, cerebral venous sinus thrombosis. You all told right. Epilepsy means is another. If the patient is already a history of epilepsy, then the patient will have a convulsion in the early purpurium, and it may can cause generalized tonic-clonic seizures as well. Okay. Now come to the next part. What agents that has to be avoided? I think you told right, but yes, that has to be taken care of like this, that ACE inhibitors first and ARB are both contraindicated in management of acute management of preeclampsia. Why? Because there is chances of neonatal renal failure, and then the patient will have a delayed onset of action. It takes around 1 to 4 hours secondary to their delayed onset of action. So one important is neonatal renal failure, especially if you are using ACE inhibitors as well as ARBs. Now, always use cautious if you are using nifedipine, because many of these patients, if the patient is landing up in eclampsia with having a seizure, so you want to give a magnesium sulfate, so it get a bad interaction with nifedipine. That's why it has an exaggerated hypotensive response. I think one of the student have already told, but they have to answer like nifedipine can cause exaggerated hypotensive response when it is combined with magnesium. And then commonly used drugs are hydralazine, labetalol, nicardipine, and nifedipine. So nifedipine with some problems if you are using with magnesium sulfate. So at least these 4 important points has to be there. Okay. Now come to the next part. So we are now coming to the next scenario. Okay. Okay, voice breaking. Just wait. I think my network is fine. Now see the next scenario. The scenario case Vignet 2. Now after 1 week, so the patient has been diagnosed with preeclampsia. Now after 1 week has passed, and now the patient has started complaining of abdominal pain and nausea with a normalization. Now blood pressure has normalized a bit. You all guys have given a good drug for management of this patient. The patient was on labetalol, and then the blood pressure has been managed, and now but the peripheral blood smears was showing helmet cells or presence of Burr cells, and the patient was having an elevated AST, elevated ALT with more than 87 international unit per liter. His serum haptoglobulin level was less, and the patient was having a elevated serum bilirubin, and platelet count was 88,000. Okay, and in the next part you can see how this is peripheral blood smear is showing. So this is you can see that how this is helmet cells. So these are helmet cells. Again, these are helmet cells. So this is basically your cystocytes. Now, based on this information, this is question number 1. So what is the diagnostic criteria of HELLP syndrome, and enumerate the name of 2 classifications. So who is going to tell me the diagnostic criteria of HELLP?
The Mississippi and the Tennessee classification.
Very good. So first is Mississippi classification. So class 1 is more severe or less severe?
More
More
class 1
severe,
is severe,
platelet
sir.
count less than 50,000.
Very good. So it is more severe classification. And second classification is?
Tennessee system
Tennessee. Very good. So I think in the previous batch, when I was taking exam on live exam, so many of the students were telling them Mississippi, but they doesn't used to tell us about the tennis classification as well. But at least you have to remember, because you can't know whether maybe the examiner is going to get asked about this question. I'm not sure whether it has been asked till yet or not, but definitely Mississippi is much more important than tennis classification. But at least if you are reading about HELP, you should know this too. Okay. Now, what are the 5 differential diagnoses of HELP syndrome? Now, again, it's a simple one. Who's going to attempt this question?
Acute fatty liver of pregnancy, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, autoimmune hemolytic anemia, and acute
Very.
hepatitis of pregnancy.
So who is this?
Priyanka.
Priyanka. Very perfect answer. So Priyanka, can you able to tell us what are the complications of HELP syndrome?
Complications, subcapsular hematoma of liver. There could be eclampsia, acute hepatic failure, coagulopathy, DIC.
Okay.
And,
So now how are you going to manage this patient? Help.
so first we will treat the blood pressure, manage blood pressure. Also, so
Blood
the
pressure is already
management
managed. Priyanka,
management
pressure
is
is already managed.
symptomatic. So if the patient is presenting with bleeding, low platelets and hemolysis, so we have to manage accordingly. We will transfuse blood and blood products according to the investigations.
So do you want to add systemic steroids here?
Uh, yes, we should add systemic steroids.
Steroids you want to add. Okay. Anyone who wants to add or doesn't want to add systemic steroids?
Yeah, we have to add it. Improves the platelet count.
Okay. So we'll have a discussion then. Okay. And then last question, what are the indications of cesarean? I think again, it's a straight question. Cesarean sections in HELP syndrome, what could be the diagnosis? What could be the problem when you ask for this patient for going for cesarean? If the patient will have some breech delivery or some fetal abnormalities, abnormal presentation, fetal distress, something like that. Okay. So let's go one by one. I think many of been answered by Priyanka, has been very well. Uh, I think very well. Let's see. So first, Mississippi classification, no discussion. Class 1, platelet is 50,000 cutoff, and class 2, platelet 50 to 1 lakh. Class 3, platelet more than 1 lakh to 1.5 lakh. It is more severe. Class 1 is more severe. Many of the time they can ask that which is more severe class 1 or 3. So don't go with 3. Class 1 is more severe. And for tennis classification, again, true or complete. So again, it is dependent upon your platelet, AST and LDH. So if you're carefully looking for those values, the AST and LDH is more than 70 and more than 600 in almost all the cases. Only the changes is in the platelet count. So based on the platelet, the classification has been there, but AST and ALT is almost same in all of the groups except in class 3, where AST and ALT is more than 40 only, not more than 70. But rest in other two classes, it is 70, and it is almost equal to this in tennis also. So in tennis, they have kept a platelet count of less than 1 lakh. In partial tennis classification, they have added the patient will have a severe preeclampsia with any of the following, like the patient will have a breakage of HELP, like the patient will have a ELP, means elevated liver enzymes and low platelets, and then the patient will have a HEL, that is your low platelets, and then the patient will have a elevated liver functions, and then the patient will have a low platelets. So it is a combination of all those. Okay. The first is finished. The second part is differential diagnosis. I think she enumerated very well. So AFLP, viral hepatitis, AITP, acute autoimmune thrombocytopenic purpura, then TTP and HUS. So TTP and HUS is very common complex. So it has to be remembered, like TTP and HUS complex is already there. So if TTP is there, HUS will be there, and autoimmune thrombocytopenic purpura and acute hepatitis as well. So now complications, I think again she has enumerated very well, like DIC, pulmonary edema, acute renal failure, hepatic rupture or hepatic infarction or periportal liver dysfunction. So you can remember these two parts: hepatic rupture and hepatic infarction, ARDS and placental abruption. Okay. Now coming to the next, how will you manage? Yes, manage delivery. Delivery is the prime target. Delivery is the prime target because fetus and placenta is the mainstay of the treatment. Timing of the delivery is very important, and it depends upon the severity of the syndrome, maternal and fetal stability, and gestational age. So all three has to be told in front of the examiners. That timing of the delivery is again very important, and treatment should be supportive. That I think she was very well answered that point also. So if you'll delay the delivery for a period, there should be a significant fetal immaturity as well. And now administration of systemic steroid had shown to reduce the risk of neonatal respiratory distress syndrome. So to decrease the incidence of, or to decrease the risk of NRDS, like neonatal RDS, the systemic steroids has to be given. Okay. Now, what is the role of administration of systemic steroids in management of HELP syndrome? Now, you carefully look for this statement from the Cochrane database 2010. So they have given a statement that if you are using systemic corticosteroids in HELP syndrome, it may increase the maternal platelet count. It may increase the maternal platelet count, but it has no proven role for improving the progression of the HELP syndrome or HELP disease or maternal or infant mortality. So your answer will be only complete treat, if you'll tell like that yes sir, for systemic corticosteroids increase the maternal platelet count, but it has shown no improvement in the progression of the disease or maternal or infant mortality as per Cochrane database. You can say like that, so you may get good marks. Okay, now coming to the next part. So this is again, I think we have already discussed that.
Excuse me, sir.
Yeah, please.
Sir, the question was whether we have to use this steroid or not.
Hmm. So the question was, what is the role of administration of systemic steroids? So here, one thing is, if you want to administer systemic steroids, definitely it will reduce the risk of neonatal RDS. Everyone agrees on that. But if further further database analysis, they found that platelet count is also going to get increased, but infant mortality is in spite of decreasing the risk for neonatal RDS. If respiratory distress syndrome is there, in spite the patient will have an infant mortality. So no mortality benefit has been found on maternal as well as neonatal part. Okay.
Yes.
Let's go to the next part. So now I think this again slide is important. I have taken from a journal, I think, and here what they have given in HELP syndrome, that you have to do a cardiac topography. So cardiac topography is important for continuously monitoring your FHR. And then here the vaginal delivery is not contraindicated if your cervix is favorable. Many of the time this vaginal delivery in HELP syndrome is contraindicated because our target is to deliver the fetus, but only if the mother is stable, if the cervix is favorable, you can attempt a vaginal delivery as well. But if HELP syndrome is coexisting, definitely high dose corticosteroid is required, and there should be a multi-modal involvement of your team as well. If the patient is going in third stage of labor, you can manage using your 5 to 10 units of oxytocin rather than symptometrin as well as ergometrin, because they will abruptly increase the blood pressure and it will maybe lead to more blood loss later on. That's why third stage of labor, you can manage this patient with oxytocin. Okay. Indications for cesarean section: non-reassuring fetal status, abnormal fetal status. Now here, two catches there. If you'll go further details for studying this, so if the patient will have a low Bishop score less than 5 and less than 30 weeks of gestation, it's an indication for cesarean section, especially if the patient will have a coexisting HELP syndrome. And second point, if the patient will have a low Bishop of less than 5 with intrauterine growth retardation, definitely, or oligohydramnios, you have to go for cesarean section if the age is less than 32. And if the patient is having a subcapsular liver hematoma as well, you can go with a cesarean. And suspected abruptio placentae cases also requires a cesarean section. Okay. Now the same patient, we have taken this patient inside that operating room. The cesarean sections, we have done a cesarean. We are trying to do a cesarean section in this patient because the indication was abnormal presentation of the fetus. But what has happened immediately after taking this patient for cesarean section, the patient was started hypoxemic. The saturation was fallen to 82%. The patient was having a sweating, shivering, dyspnea, cyanosis was also there. The patient was started bronchospasm. The height vitals was the blood pressure was very low. The respiratory rate, she was very tachypneic. The temperature was almost closer to hypothermic range. So she was having a shivering, and then the patient was having some sweating. The patient was having a heart rate of 78 beat per minute. So at this point of time, I just want 5 risk factors for AFE or potential pathophysiological process, and then how could you diagnose for this parturient patient, means what could be the differential diagnosis if the patient will have a profound cardiorespiratory compromise. So who is going to attempt this first question? I think first is simple one. At least 1, 2, 3, 4. Anyone? Anyone? Don't take more time, because then we will have a lesser discussion. Anyway, anyone who wants to attempt that second question, like 12 number? Potential pathophysiological process. Why hypoxia is there? Otherwise, I will just try to explain you all.
There occurs VQ ventilation perfusion mismatch in AFE, so that's responsible for hypoxemia. And
Good.
also because the emboli, they get lodged in the right side of the heart, so they lead to decreased in the cardiac output to the left heart also, and that causes hypotension. um,
Okay. Good. So you told first very right that VQ mismatch is there. Yes, true. Anyone
Let me add
wants
something.
to add
Pulmonary
something?
edema.
Yeah,
In
John?
addition, there's
Yeah.
also an acute inflammatory process that
Yes.
occurs in the lungs
Hmm.
in amniotic fluid embolism, just like in pulmonary embolism.
Yes. So I think yes. Do you have any
Yeah.
differentials? Do you have any differential diagnosis for amniotic fluid embolism at this point of time? What could be the other causes for this profound cardiorespiratory compromise? Which the acute pulmonary embolism? Yes, you told right. What else that could be?
Other embolism like venous embol means
Okay. Anything else?
Circular to
any cardiac
collapse
causes, myocardial infarction.
rupture the center
Yes.
or
Yes, right.
and so risk factors are like advanced maternal age,
Mhm.
multiparity, and previous history of
Mhm.
assisted labor or prolonged labor.
So you're not very clearly audible, Anika. Oh, would you like to enumerate what are the parameters in DIC score?
So DIC is a 40 score,
Hmm.
presence of thrombosis,
Hmm.
neutropenia, and
Hmm.
timing of onset 5 to 10 days,
Hmm.
and absence of any other cause of thrombosis
Hmm.
evident. So these are the four parameters, and the score is each parameter is given score of 0 to 2. So the
Hmm.
maximum becomes 8 score, and that's how we label a patient.
Okay. So have you read about overt DIC or non-overt DIC? What is non-overt DIC?
Yes.
No. Okay, not an issue. I think you told a few of the things right. And anyone who will be going to tell me the biomarkers for acute fatty embolism, or sorry, amniotic fluid embolism, AFE? Any biomarkers? I have taken a class initially.
The
Okay,
CEA, the CA 125,
very good.
and interleukin 6,
Yes,
IL-8,
yes.
TNF alpha.
So this very well, Gandhi. I think this question has been not asked right till now, till date, but maybe many of any of the time it could be asked in your exam. Okay, so at least my only request is for you all to just for a sensitization that at least you dive into amniotic fluid embolism. You read all important aspects, and definitely these three, four will save you and will give you you will going to get good marks also. If in future they will ask, I'm not sure whether they will be going to ask in this exam or not, but at least our level should be like that, our preparation should be like that. Okay, so I will be not wasting much time, so I will straight away going. I think Priyanka has enumerated many of the risk factors well, like advanced maternal age, forceful uterine contractions, then your cesarean section delivery, grand multiparity as well, placenta previa, cervical lacerations, eclampsia. So long list is there, but in the exam they will not ask such a long list, but at least three or four factors they may be asked. In this patient, the patient was having a instrumentation delivery, like cesarean section was done. The patient was grand multipara. The patient was having. The patient was having here again risk factors was abnormal presentation of the fetus, so abnormal fetal presentation, as well as the fetal distress was there, one of the findings. So many of the finding mimicking with amniotic fluid embolism. And then the potential pathophysiology, again she told right that there is a common ventilator perfusion mismatch. And I think one another uh, candidate has also told us about that changes in the pulmonary edema as well as pulmonary vasospasm. So all these contributing to hypoxia and bronchospasm also. So there is mismatch following pulmonary edema leading to your acute left ventricular failure, and then the patient will have a Hypoxia. Now, other diagnosis, I think again, many of you have enumerated very right. I was happy to listen about myocardial infractions with acute LVF, then septic shock, pulmonary aspiration, anaphylaxis, pulmonary embolism, and air embolism. I think this is one of the common answer that everyone should know. If amniotic fluid embolism, the common hemodynamic instability will be there in pulmonary embolism, but never forget about anaphylaxis, never forget about pulmonary aspiration, never forget about myocardial infarction with acute LVF. So these are one of the important DDs. Okay. Now, what are the parameters of DI score? I will quickly go through for your revision that ISTH classification. As per your ISTH classification, the patient will have a INR. The only INR, if you are doing INR and the patient is having INR of more than 1.7, the score will be 2, or any of these three. Like the patient will have a PT prolongation, fibrinogen, D dimer, and platelets. Okay. So if the patient will have a prolongation in the PT, like if it is more than 6-7, the score will be 2. If fibrinogen level is more than 100 milligram per DL, so it fetches 0 point. But if it is less, if it is consumption, so it is 1 point. And D dimer, if it is moderately increased or severely increased, only for the D dimer, the 3 point is there. So in the exam, they may ask that which fetches maximum values for DIC score. So it is D dimer which fetches the maximum values for the score. It fetches 3 points for if it is increasing more than 10 times the upper limit normal. And for platelets, again less than 50, more than 100, and 50 to 100. So I ask one more thing about non-overt DIC and overt DIC. So if you'll see, if the patient will have a 5 points, more than equal to 5 points, the patient will have a positive for DIC. But if the patient will have a less than 5 points, it is negative. DIC is not there, but the patient still could have a non-overt DIC, which could evolve into a frank DIC. Anytime this patient can be converted to a frank DIC, which has to be. That's why the ongoing DIC is a concern in this patient. And so the lab reports or coagulation parameters has to be repeated every 12 to 24 hourly. So in a day, you can do a 2 values, and then after 24 hours, either after 24 hours, you can do a DIC calculation. So again, it is important. So I think in DIC, if they will ask the question, it should be like that only, that which fetches maximum and what is the cutoff value, what is the D dimer value, what is the platelet value, and what is the prolongation. When you will say that PT prolongation, like less than 3 seconds, 0.326. So prolongation will start from more than 3, and it is maximum prolongation is more than 6. So this is overt, non-overt DIC. Okay. And I think, yes, lab finding acute DIC, definitely in DIC, platelet count, thrombocytopenia, fibrinogen level will fall, PTNR prolongation of PT will be there, PTT will also increase, you will get a cystocytes, helmet cells, you will get a more D dimer, more than 10 times upper limit normal. So score will be 3. So always try to remember that. Now, coming to the next part, I think I have added here for you all guys that what is overt and what is SIC, that is sepsis-induced coagulopathy. So if you'll see in the y-axis coagulopathy with time, if the time will be more here with sepsis, the platelet count and the PTNR will be affected. So the patient will have a sepsis-induced coagulopathy, which is also known as early phase DIC. Here, the platelet count, PTNR, and total SOFA score has to be taken care of. Okay. And if the patient will have a over DIC, you will have a platelet, prothrombin time, fibrinogen, D dimer, and then DIC diagnosis. So how will you make a DIC diagnosis? If your total score is more than equal to 5 with divide by 8. So out of 8, if the patient will have a more than equal to 5. So this is your diagnosis. So it is changes with time. Coagulopathy changes with time. More time, more coagulopathy. Lesser time, if you get a diagnosis, I think you will save the patient. Now, biomarkers, I think many of you have answered very well, like CA125, your CA1 esterase inhibitor, CEA, then I think interleukin 6 has been also been answered. And then I think activin A, brain natriuretic peptide, you can remember, it's fine. If you not remember pro-collagen type 1, it is not important, but at least these 3 or 4 is important. CA, chromogranin A, and then endothelins, insulin-like growth factors 1, like IGF, FBP1, and then your interleukin 6. If you remember interleukin 8, it is fine, otherwise not an issue. Okay. Now coming to the next part. So how are you going to manage? Yes, you want to give 100% oxygen with positive pressure ventilation. You want to push more large amount of blood volume because cardiac dynamic instability is there. You have to push fresh frozen plasma. You may decide for transfusing platelets, fibrinogen concentrates, or cryo based on the TEG for managing DIC, or you can do TEG at this point of time. Thromboelastogram you can do, and you can check both the values like coagulation problems and fibrinolysis. So based on your R value, based on your K value, based on your alpha, and based on your maximum amplitude, you can try different drugs. Can anyone tell me what could be the treatment if the patient on TEG in the thromboelastogram you are saying that the patient is having a lesser amount of R. So if R is very less, what you want to add in this patient?
Estrogen plasma.
Very good, perfect. So if the patient has a low R and if the patient have a low K value, then what you want to give? Low K.
Sir,
So you want cryo.
precipitate.
Cryoprecipitate. Very good. So cryo is there. So at least you all guys have this preliminary knowledge about this tag and interpretation of tag. This is important. That when to add your FFP, when to add your cryo, when to add your tranexamic acid, when to add your EACA, that is immunocaprionic acid, when to add your platelets, apheretic platelets. So that has to be very clear. Okay. Now you stabilize and then transfer this patient to the ICU. Now what has happened to this patient? Now you see. Next is, now this patient was immediately shifted to the obstetric ICU. We managed this amniotic fluid embolism on third. So I will be a bit fast because I think time is less. On third day, ICU admission. Now his blood pressure got stabilized. Anyone got stabilized. The other vital parameters also started to improve, but the problem was there. The patient started complaining of epigastric pain and then few episodes of vomiting, and then the patient was having a hypoglycemia, which is inside the ICU only on 5th day after admission. So patient was having pallor, icterus, pedal edema, and slight change in altered sensorium. So this is on third day of ICU admission. Patient has been delivered, and then the patient was having these features on 5th day after ICU admission. On third day, she got admitted to the ICU. So at this point of time, I want to ask, what would be the serious condition in this patient leading to dealing in the postpartum period? What condition we are dealing with? Can we have a enumerate pathophysiology? Can we have a 5 important diagnostic feature of AFLP? So now, till now, at this third question, now we are sure that the patient is having acute fatty liver of pregnancy, because third trimester of pregnancy, delivery, even after delivery, the patient can have a AFLP many of the times. But if the patient has been developing AFLP and baby has been not delivered, so delivery of the baby is utmost choice, and many of the time the patient going to get improved. But overall, the AFLP mortality depends upon that the change in the liver function test. So if the liver function is very poor, if the bilirubin is very high, if the Swenson criteria is fulfilling by the patient will have a severity of AFLP. So this is one thing. So how will you differentiate HELP from AFLP, and what steps in the management? So I will not take much time. Only anyone who wants to I will go with pathophysiology. I will not ask pathophysiology. I will discuss pathophysiology, but I want that how will you differentiate HELP from AFLP? 3 points. Anyone?
Sir, in AFLP, patient will have microvascular fat deposition.
Okay. Microvascular steatosis you want to tell, na, Pankaj?
Yes, sir.
Okay,
Then can
very good.
have hypoglycemia.
Very good.
Very,
Think you're right.
very recurrent
Yes.
hypoglycemia.
Very good. I think this is hypoglycemia, one of the feature which differentiate HELP from AFLP. You are damn right. Now you just see that
also
we are going to discuss in a very quick fashion. So it is important. Why this mechanism of action is important about acute fatty liver of pregnancy? So there is the mechanism will be happening at 3 different levels, from at placenta, at the circulation level, and at the liver level. So what will happen? There is a fatty acid oxidation defect. So what this placental fatty acid oxidation exactly does? Basically what happens, if the patient will have a normal fatty acid oxidation, so the patient will have a free fatty acid, more formation of acyl CoA, and then acyl CoA and acetyl CoA will forming more. And if the patient will have a problem in the fatty acid oxidation defect. Why this problem is going to get happen? Because of the defective enzyme, that is 3-hydroxyacyl CoA dehydrogenase, that is LCHAD. So it is not very common mechanism, but this is one of the proposed mechanism for development of acute fatty liver pregnancy. So what it will all do? So if the fatty acid oxidation defect will be there, no conversion of acyl CoA, no formation of acetyl CoA will be there. So large amount of free fatty acid will be going to get accumulate inside that mitochondria, leading to oxidative stress, more lipid toxicity, more lipotoxicity. So all these free fatty acids is going in a circulation as well. And now what will happen? Your 3-hydroxyl acyl CoA will be also going to get formed, and this is also going to get accumulated inside that placenta. And the problem is, because you have a LCHAD deficiency, so it is not forming. So this will also increase the level. So hydroxy fatty acids level will increase, free fatty acid, oxidative stress, nitrosative stress, antioxidant values will be falling so much. The patient will have a microvesicular steatosis, which you told very right. The patient will have a mitochondrial dysfunction. The patient will have a hepatocyte lipoapoptosis. So if in nutshell, if you want to answer, just one thing, that the patient will have a fatty acid oxidation defect due to LCHAD enzyme deficiency. The patient will have oxidative and nitrosative stress. The patient will have a more free fatty acids. There will be lipid accumulation. There will be apoptosis. There will be microvascular steatosis. That's it. No point in adding more and more. They will understand that you know at least the basic physiology of AFLP. Okay. Now come to the next point quickly. Swenson criteria, I will not go in details, but only two important points that in every class I used to tell, that hypoglycemia, one of the very, very common complication, very, very frequent complication, or very, very frequent presentation. And then the patient will have a ammonia, elevated ammonia level. So many of the times the ammonia will be more than 47 micromole per liters. The patient will have an impairment in the renal function. The patient will have a more APTT. Liver biopsy on doing liver biopsy, the microvascular steatosis will be there. Okay. And the means few patients may present with polydipsia and polyuria, but not all patients, but few of them are there. So now what you will be going to do, if the patient will have a 6 or more criteria, so your AFLP is the diagnosis. Okay. Now this is differentiation. I think you already told it very right, that common presentation, hypoglycemia, first one. Second, very carefully see, there is a variable presentation in HELP for DIC. So in DIC, the HELP will be variable in DIC, but it is almost absent in TTP-HUS. It is very common in AFLP as well. And the patient will have a decreased level of antithrombin 3, which is again a common finding in AFLP. Okay. Rest, like transaminitis, 3+, 2+. Hemolytic anemia, 1+, double plus. So this HELP will have more hemolytic anemia. Thrombocytopenia, almost similar. 1+, you can't differentiate based on thrombocytopenia either for AFLP or HELP. And for antithrombin deficiency, yes, definitely. This is again the second part. So if they will ask about that 3 different points, so you have to tell hypoglycemia first, then your antithrombin deficiency second, and then your transaminitis third. So I think this could be, and almost 100% of the patient, 20 to 100% of the patient is going to have a renal insufficiency. So renal involvement have to be there. But here, the renal involvement is around 80%. Here, lesser renal involvement is there. So if lesser renal involvement is there, so you can differentiate a HELP syndrome from AFLP to HUS and TTP. Okay. So this is in nutshell. What you're going to do, you stabilize the maternal stabilization, and then if you try to prolong the pregnancy for the diagnosis, so there is more risk of development of this fulminant hepatic failure. Many of the patient, we have seen that the patient is landing up in hepatic failure that is fulminant in nature, and then the prognosis is very, very worse. And here expected management, don't think of expected management at all. You can do a delivery as soon as possible. There is no report of AFLP resolving prior to delivery. So there is very lesser report. Many reports are there that AFLP is going to resolve only after the delivery, not before the delivery. Okay. Now the similar patients, pre and postpartum treatment should be supportive. Plasmapheresis, yes, plasmapheresis may be considered. We will have a discussion on plasmapheresis as well in this class. May be considered where liver failure continues to worsen despite therapy. chemotherapy. So it is one of the factor. And then in extreme, you have to go with a OLTX, like orthotopic liver transplant is the definitive treatment. So I ask one question, that what is the initial sign of hepatic recovery in FLP? So if your prothrombin time is started to improve, it is going less than 3 seconds. So it means the patient AFLP is going to get recovered. So this is a most important sign showing that AFLP, the liver recovery has been started. The second part is normalization of the liver enzyme, ammonia, coagulation studies, then serum creatinine, and then it takes around 10 days after delivery, liver function will be returning to normal. Okay. Now coming to the vignette 5 here, now the patient have a yellowish discoloration, recurrent non-bilious vomiting, increase on 7 days. The patient was afebrile, drowsy. Now flapping tremor has started to come. BP is normal. Pulse rate is bit tachycardic. SpO2 is maintaining. She's having a respiratory. Respiratory rate is also fine. SpO2 is also fine. Pulse rate is almost acceptable. Abdominal features showing no shine, no hepatosplenomegaly, no dilated veins over abdominal wall, but she was having a hyperleukocytosis, thrombocytopenia, hyperbilirubinemia, transaminitis, and coagulopathy. ABG is normal. Urine depistic protein is negative. Now, at this point, we have started our case with positive urine depistic positive, and then the case is now the case is negative, and then after that. The question is this. So, what is the diagnosis? What are the etiological agents responsible for leading to this other than AFLP? So I have already discussed that patient may be developing in fulminant hepatic failure. Many of the time, if you are not going to manage this patient, the patient will have a hepatic fulminant hepatic failure. And then persistent organ dysfunctions. Why she has persistent organ dysfunctions despite emergency cesarean delivery, and what is the role of therapeutic plasma exchange in the management of above case? So quickly I will go. Next question: how does this TP work in liver failure patients? And then explain 5 important adverse events. What is the main limitation, and what is the role of combination of double DP mass, like double plasma membrane absorption system? So DP mass is, don't confuse DP mass with Mars. Mars is different. DP mass is different. Mars is more Mars has been mostly is a liver dialysis, but here it is DP mass is mostly combined with therapeutic plasma exchange. Just few words about these two important things. That why, if the patient is having a jaundice with pregnancy, in the late pregnancy, so AFLP definitely will think of, but always try to exclude chronic liver disease, portal hypertension, whether the patient is having some pre-existing portal hypertension, or whether the patient is having some pre-existing liver disease. Then always try to rule out your malaria, and then your acute viral hepatitis. I think many of you have already told about it, that if the patient is having a jaundice in late pregnancy, rule out acute viral hepatitis. How will you rule out acute viral hepatitis? By doing a battery of tests, like you can do with hepatitis A, then your hepatitis B, then your hepatitis C, and then D, and and then E. So here in hepatitis B, you have to do anti-HBeAg, that is HBsAg, HBeAg, then your anti-SCV, then your viral load DNA, you can go with that also. And after thinking that the patient is going in ALF, so what could be there? Whether the LDH is increasing, whether the thrombocytopenia is there, or whether the preeclampsia is there. So if background preeclampsia is there or not there, you can think of HELP syndrome. If the background is having, the patient is presenting with hypoglycemia, encephalopathy, or coagulopathy, consider AFLP. And in both the cases, either HELP or either AFLP, the treatment is almost same. So you have to start urgent delivery, antibiotics, and then hypoglycemia. Okay, so this is how to approach a jaundice in late pregnancy. So these are 4 important: first CLD, portal hypertension, acute viral hepatitis, malaria, and then HELP, and then AFLP. Okay, now okay, few things about your non-biological artificial liver. So NBAL is basically used as a treatment method. So it has basically psychochemical, biological. So it has discussing about what is this biological device and how it works, how this works. Basically, these biological device removes the toxic substances and it improves the internal environment. That's why it replaces the functions of the failing liver temporarily. So that's why it's a bridge before you start a liver transplantation. Okay. So NBAL is non-biological artificial liver. Now see, so till date, this non-biological artificial liver has been applied in clinical practice, and its effectiveness has also been established. And among NBL, this plasma exchange is one of the most common technique. Why? Because it uses a plasma separator to filter the plasma from the whole blood, and then it removes the toxin substance, and then again, all after removal of all those toxic substances, the full blood or plasma is again going to get is given to the patient along with fresh frozen plasma or white to replace the coagulation factors and albumin. Now you see quickly that how this DP mass system is going to get formed, because if in double plasma molecular absorption system, now you use a plasma filter which continuously going to separate the plasma. So a plasma filter is there. Now importance about this plasma filter is they have a specific bilirubin absorbing system. Okay, so they have a basically a specific absorbing system which is a bilirubin absorber, and it has a macroporous resin hemoperfusion device. So there is a device and there is a absorber which removes the toxic metabolite, and either this metabolite could be a large size or a medium size bilirubins, and then some inflammatory mediators is also going to get filtered through it. And now then the plasma, after the removal of all those large or medium size bilirubins or inflammatory mediators, the plasma is again transfused back. Here only the thing about in DP mass along with TP is that there is no substitution of fluid. What we used to give in TP, we used to give fresh frozen plasma, but here no substitution fluid is required, only because they have a pump and they have a macroporous raising hemoperfusion device, and then they have a specific bilirubin absorber system. That's why it is more effective when you are combining TP with your this DP mass. Now this is one of the TP. How does this TP work? TP is basically taking away. So apheresis. So which molecular weight? More than 15,000 Daltons. So what are those? Autoimmune, immunocomplex, cryoglobulins, endotoxins. I'll not go in details. And then the next point is, so how it is going to work? So this is a patient. So now what it will be, what we are going to do, a blood pump is there. So what it will be doing? It will be fetching the blood. It will be fetching the blood, and it is passing through that plasma filter or which based on osmotic pressure gradient. And after that, what will happen here is some anticoagulant is also been pushed into the blood, and then through that and then through this plasma pump here, all those toxic metabolites will be absorbed. Okay, and then it will go into a vest, and then after this filtration, one more pump will be there which will be pulling all those substitution fluid like FFP, and through plasma separator again it will go to the blood. So it is basically a veno-venous exchange, not arteriovenous, just like what we have read in ECMO like VA or VV. So it is basically a VV exchange is there, and then there is a three pump which really functions in plasma exchange when you look for the whole machine. But the concept is substitution fluid is not been used in DP mass, whereas in the therapeutic plasma exchange it has been used, and the absorbing system is bit more different in your DP mass. Now, the next point, these are the few chains of problems or chains of side effects that is going to get happen. And I'm sure that many of you guys must be knowing those, like paresthesis, like hypotension, like anaphylactoid reactions, clotting, hemorrhage, infection, pneumothorax, and all. So now here, what two important point is their discussion is proposed mechanism of TP helping in hepatic recovery include things that it removes the toxic substance and it provides the supplementation of coagulation factors. That's one, and albumin. So these two things is important. And then many of the times this TP also induces superoxide dismutase and it inhibits malondihyde production. So how it is going to prevent hepatic apoptosis because they are going to inhibit the upregulation of caspase 3 and caspase 9. So this is a bit more advanced, more in detail. So it is only for your information that it inhibits the upregulation of caspase 3 and 9 by producing enzyme malondihyde and preventing hepatic apoptosis. Now, what will happen if you combine combination therapy with TP in liver disease? So I have already discussed that one of the major drawback of TP that it is not able to remove the substances which is lesser than uh, 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 50,000 kilodaltons, and non-selective nature because it is non-selective because it leads to removal of albumin and immunoglobulin. So it has one of the more drawback that it removes albumin and it removes immunoglobulin as well. That's why the thing has changed and DP mass system has been there because it uses a plasma filter which continuously removes the plasma and it removes the medium size, like if the size is less than 50,000 kilodaltons, and which with preservation of albumin as well as immunoglobulins as well. That's why the changes in albumin global is not that much significant that what you find in TP. And one more thing is there. If you combine DP mass with TP, what happens? That survival is improved as per one of the study. And then in the recent meta-analysis also that DP mass with TP, they have found that greater improvement in the bilirubin and INR is there. So these are the things for all those setups where it is not possible to do a liver transplant. Orthotopic liver transplant is not possible in those setups. So you can definitely use this DP mass with TP technology. But the major limitation is that they have predominantly performed in patient with hepatitis B related acute fatty liver of pregnancy. Acute liver failure or acute and chronic liver failures. Okay. So this is all about from my side. So I think I will be happy to take any questions if you all have, or we'll have a
So the modalities which you have just discussed, liver assist device. So it is irrespective of the liver disease, whether it is due to whether it is related to pregnancy or solely related to liver disease like acute liver failure, paracetamol poisoning, or some of the cases where it is being used in some of the toxins like Mars has been used, SPAD is being used, and other bio artificial and non-bio artificial liver devices are used. So mechanism means I want to say that either of the condition we can use this particular modality.
Yes. Why I have added? Because many of the time what will happen now, if you're a STEM, if you're in EDIC 2 exam, if you're a STEM will start with a preeclampsia, they may go up to therapeutic plasma exchange or they may go up to your DP mass system. That's why it is there, because many of the time what has happened, if the patient is having a ECMO, received ECMO, after getting ECMO the patient is not improving, the patient has went brain dead. So brain dead, organ transplant, after organ transplant they have retriever of organ, they are asking all those solutions, then cold ischemia time, war ischemia time, like that. That's why I have added this part only for you all guys to go and read. Definitely DP mass as well as your therapeutic plasma exchange still have of very limited values. They have a very limited results in management of acute fatty liver or pregnancy, but definitely it's a bridge to therapy if you are planning for orthotopic liver transplantation in any of the patient. So the cause would be any cause related to the liver, either acute or chronic liver failure, any form of hepatitis, fulminant hepatic failure, or the pregnancy induced fulminant hepatic failure. That's why I have conglomerated all those things for you also, that in the exam they may go to that extent. Okay, you got it. That's why, because to have some basic idea about therapeutic plasma exchange and DP mass and Mars system, how these mechanism really happens. And if you all guys will tell this, like substitution fluid is not been used, the chances for albumin means will be more restored, the immunoglobulin will be less worst with this technology. I'm sure that they will understand that you all guys have read in that depth. That's why I have added that. Okay.
Yes.
Okay. Any other question? Sometime in patient with acute liver failure morts despite extensive work etiology not how to proceed for the perspective of pregnancy status. Definitely, देखो, again the thing is that you have to follow that algorithm approach. That what I told you, that if the maybe some of the rare cause of that acute liver failure will be there, or if you are doing all those workups, maybe some unusual cause would be there. You can't say that this would be, because it's a diagnostic screening is required almost at every point of time. So it depends upon the case to case basis also. Many of the time what happens, that why I have told you that algorithm. So if you have to approach your patient in that way only, if the patient will having a pregnancy with jaundice, late stage of pregnancy, how will you going to approach? Definitely you can't skip portal hypertension, you can't skip pre-existing chronic liver disease, you can't escape. If you are not answering these two important points, no point in telling about malaria and all. So these two things, so it is like that approach is to be there. And if you answer that two things well, and then you are answering acute viral hepatitis, malaria, HELP and AFLP, then definitely they will be more happy to know yes, you know that step-wise approach for treatment of those patients. Okay. So it is, Namrata, it is based on the case-to-case variation. But what I told right now, it is always a good diagnostic approach as well as algorithm approach for management of these patients. So we have started our journey from preeclampsia definition. Then we landed up into eclampsia. The patient was having a HELP. Then the patient was having a AFLP, amniotic fluid embolism. Then the patient was having a AFLP. Then the patient was having a fulminant hepatic failure. Then the patient was having a TP. We went on TP. We went on DP mass. And then one question could be again discussed about orthotopic liver transplantation. They may ask about OLTX. So you must read what is cadaveric, what is diseased, what are the indication, what is Maastricht classification, what is organ donation criteria, what is UNOS criteria. For that, you have to read all those points. What are the solutions that are being used? They may going to get asked. Anything can be asked. If you are answering well, they can go to that level. If you're not answering well, they will stop at Vignette 2. Amniotic fluid embolism. If you will tell wrong something about it, mechanism wrong. So this is all about from my side. Go and read. I think happy reading, and you all guys are doing well, and hope you all will pass with flying colors. So if you no questions, thank you so much. Or if you'll have any question, you can come back to the Forge Academy. You can ask. You can drop a mail to them, and then I will be happy to answer. Okay, everyone.
Thank you, sir, for this
Thank you.
session.
Thank you. Thank you.